Welcome to the webinar, Raising Awareness and Reducing Disparities for Hereditary ATTR Amyloidosis. My name is Kevin Alexander. I'm an advanced heart failure and transplant cardiologist, as well as a member of the Stanford Amyloid Center. And thank you for coming today to talk about this important disease. This month happens to be Amyloidosis Awareness Month, and we hope that the content in the next hour will help to raise your awareness and understanding of this important disease. I'd like to thank our sponsor, Alnylam Pharmaceuticals, as well as the Association of Black Cardiologists for the opportunity to bring this webinar to you all today. So in the next few minutes, I'm going to give a brief overview of ATTR amyloidosis, and then we'll go into more depth in terms of the clinical presentation. Amyloidosis refers to a family of diseases characterized by protein misfolding. In the case of ATTR amyloidosis, the protein that misfolds and aggregates is called transthyretin. It's produced by the liver as a homotetramer, so 4 like subunits that bind together. And what happens in amyloidosis for this disease, these tetramers break down into the monomer subunits, and these are prone to aggregate and clump together to form oligomers and ultimately amyloid fibrils that can deposit in a variety of tissues, including the heart, peripheral nerves, and other places. Some of the mechanisms by which the tetramer dissociates into the monomer, which is really the rate-limiting step for forming amyloid in this disease, some of these mechanisms are poorly understood. What is better understood is the hereditary form of this disease, which is caused by a mutation in the transthyretin protein. And these mutations destabilize the tetramer and make them more prone to break down into monomers and form amyloid. Dozens of mutations have been described. Some of them are shown here on the slide. Interestingly, these mutations have a diverse range of phenotypes, with some mutations such as V30M, or early onset V30M on the left side here being predominantly a neuropathy phenotype, whereas there's other ones that have a predominant cardiac phenotype, such as the ones in red on the right. And there's many that have a range of neuropathy and cardiomyopathy symptoms. And even ones that have a predominant neuropathy can have a small degree of cardiomyopathy and vice versa. So really a broad range of disease manifestations. I'd like to draw particular attention to the V122i variant. And that's because this variant is relatively prevalent in this country and by far is the most common cause of hereditary ATTR amyloidosis in the US. This variant is carried by 3 to 4% of African Americans, meaning there's over 1 million carriers in this country alone. An observational study we did a few years ago looking at death certificate information to ascertain reported amyloidosis mortality across the country, we found that African Americans, particularly men, had a significantly higher reported amyloidosis mortality compared to other races. And I think a lot of this mortality is being driven by the presence of the V122i variant. So this is increasingly recognized as an important cause of heart failure among African Americans. In the same study, we looked at geographic variation in the reported amyloidosis mortality. Shown here on this heat map, you can see that there's certain states in the upper Midwest and Northeast that have much higher reported amyloidosis mortalities compared to other parts of the country. And when we looked in more detail to the counties and cities in these areas, we found that certain cities or certain counties actually had even higher rates. For example, Rochester, Minnesota had a several-fold higher rate of mortality compared to the surrounding Minnesota area. And ultimately what we found was that places that had amyloidosis centers of excellence, such as Mayo Clinic or Boston University, some of the oldest amyloid centers in this country, the reported mortality was much higher, suggesting that in areas where there's experts in amyloidosis and there's increased physician awareness, doctors are more likely to pick up this disease, and that's how it made it onto death certificates. So I think these data highlight what a lot of us in the field have known, is that this condition is underdiagnosed, and it requires increased awareness and education among the healthcare community in order to pick up cases. Another thing that we noticed in this study One thing you might hypothesize, I showed you data that amyloidosis mortality is higher among African Americans, that states that have higher proportion of African Americans, such as the Southeast, would have higher reported amyloidosis mortality. And we found the exact opposite. Places such as Alabama, Georgia, et cetera, had some of the lowest reported mortality rates. And so while there's a pattern of underdiagnosis across the country, there's an even higher rates of underdiagnosis, I believe, among African Americans. In this particular group, we need to have improvements in disease awareness and come up with strategies to diagnose this disease earlier. So we'll have 3 talks. First by Dr. Jaraday, looking at ATTR neuropathy in the clinical presentation. I'll talk about ATTR cardiomyopathy. And finally, we'll have a talk by Dr. Haynes about health disparities among African Americans, challenges and solutions. With that, I'd like to introduce Dr. Safwan Jaraday, who is a professor of neurology at Stanford University, as well as he's also a member of the Stanford Amyloid Center, and he'll be speaking to us about hATTR neuropathy, presentation, and diagnosis. Dr. Jaraday.
Thank you, Dr. Alexander. Good afternoon, and again, I wish to thank the sponsors for inviting me to speak. I'm a neurologist trained in neuromuscular and autonomic disorders, and I'm a member of the Stanford Amyloid Center, and as a result, I evaluate and manage patients with amyloid neuropathy. And you've already heard from Dr. Alexander about the TTR and how basically it involves instability. The mutations make the tetramer less stable, favoring monomers, and as a result, they will precipitate in the tissues. When you look in the case of amyloid neuropathy at a nerve biopsy under a light microscope, you will basically, if you do a Congo red stain, you will find first signs of axonal degeneration, as you see digestion chambers in the myelinated fibers, and you will see amorphous congophilic material deposition in the nerve, and these will be the Congo red positive amyloid deposition. If you do a semi-thin section of the nerve and stain it with toluidine blue, these little circles surrounded by a dark rim, those will be myelinated fibers, and they vary in thickness. And then the light blue in the background are basically the unmyelinated fibers. And the top slide, and that's taken from a paper in Lancet Neurology by Gerard Said and Violaine Planté, 2011, shows that basically in a mild neuropathy, you get a drop in the density of the fibers. And as the neuropathy progresses, you will begin to see clumps of amyloid deposition, even in underneath the endoneurium, the perineurium and the endoneurium, the intrinsic connective tissue, and you will see even a greater loss of myelinated, unmyelinated nerve fibers. And what happens is that the monomers actually tend to be toxic, not only directly to the myelinated and unmyelinated axons, but they also are toxic to Schwann cells, which surround myelinated fibers, but also surround to a greater number the unmyelinated fibers. And that explains why you get this mixture of large and small nerve fiber impairment in amyloidosis. If you do electron microscopy in these patients, you will see the amyloid deposition leading basically to choking of the Schwann cell because of their toxicity. And you begin to see areas where unmyelinated axons used to be present, basically disappearing. And the same amyloid deposition can happen, for instance, in soft tissues such as the carpal ligament, which explains why carpal tunnel syndrome, for instance, is a common early manifestation in amyloidosis. As you saw briefly from one Dr. Alexander's slides, patients who present at a younger age tend to have a positive family history. And if they are in an endemic area, for instance, and they have a positive family history, usually you can make the diagnosis by going directly to doing the genetic testing. And these patients will have a small fiber and autonomic neuropathy as well as cardiac manifestations. As opposed to patients whose onset of the disease is either later or if they have negative family history, these patients will present more often with a length-dependent sensory motor neuropathy with or without cardiac involvement, but they will also have some autonomic manifestations. And because of the lack of negative family history in these patients, they often end up requiring a tissue diagnosis to find the amyloid deposition, and that subsequently may lead to requiring the DNA diagnosis. As Dr. Alexander showed, there are various mutations, but basically they make the tetramer more unstable. And you get basically precipitation in the heart, in the peripheral nerve, and there are more than 130 mutations described. And the most common worldwide mutation is the V30M, which was described mostly in Portugal and is responsible for the so-called FAP, or familial amyloid polyneuropathy. And 4% of African American, as well as individuals of African descent and Caribbean, will carry the V122L mutation, which is more responsible for the cardiomyopathy. But as a neurologist, I look at amyloid neuropathy really as a spectrum. So you could have the V122L mutation presenting mostly with cardiomyopathy, but these patients are not immune from developing a neuropathy. And in fact, when we evaluate them here, we will find that they have a neuropathy. And basically, the V30M patients present mostly with neuropathy, but they are not immune from cardiomyopathy. And then the other mutations, including the Northern European T60A, is kind of in between. The precipitation of the tissue in the peripheral nerve causes a sensory motor neuropathy with length-dependent sensory loss, motor weakness. Precipitation in the carpal ligament leads to carpal tunnel, and autonomic manifestations dominated by orthostatic intolerance, recurrent UTI, sweat abnormalities, and sexual dysfunction. The digestive system gets double dose or double hit. First, there is direct accumulation of amyloid in the digestive tract, but also there is impairment in the autonomic nervous circuitry to the GI system, leading to prominent GI manifestations. And of course, other organs such as the retina or the eye, as well as the kidney. And there is the late onset variant called Senile Variant, which tend to be wild type, that presents with some CNS manifestations with cognitive impairment, seizures, as well as stroke-like episodes. In the neuromuscular and autonomic clinic, basically, we rely on the clinical exam, but also we use neurodiagnostic tool as an extension of our exam. So to diagnose a large fiber sensory motor neuropathy, we use nerve conduction studies as well as electromyographic testing. And we look to see, does the patient have a sensory motor neuropathy, usually axonal, with carpal tunnel syndrome. In the autonomic testing lab, we can measure the postganglionic sweat or pseudomotor function by quantitating the sweat responses using the technique called quantitative axonal reflex test. We can also measure the cardiovagal function during deep breathing as well as Valsalva maneuver. We can measure the adrenergic function looking at blood pressure responses during the Valsalva maneuver and the tilt test. And of course, biopsy of the nerve in case you strongly suspect a amyloid neuropathy will be very useful. And then the genetic test, as we speak before, particularly in cases that are familiar. As a neurologist who sees amyloid and other neuropathies, when do I suspect amyloid? Well, when I see a peripheral axonal neuropathy or autonomic neuropathy or both, and particularly if there is no adequate explanation, if there is some other organ involved, kidney, liver, spleen or tongue, heart, if there is an unexplained malabsorption syndrome, that basically becomes a very important red flag for me. And it's important to realize that when you choose the tissue biopsy, it's best to biopsy a tissue that is affected, because then your sensitivity becomes higher. But if not, the subcutaneous fat abdominal biopsy tends to have a sensitivity between 85 and 90%, except in wild type amyloid cases where the basically sensitivity drops to about 70%. And you need to stain not only with Congo red, but it will be useful to do immunofluorescence staining. And if the lab cannot have that, then maybe perhaps perform electron microscopy, because that will increase your diagnostic sensitivity. This is a slide that compares the major type of mutation, and Dr. Alexander touched on that. And as you see, for instance, the V122L presents mostly with cardiomyopathy, but there is also a high incidence of peripheral neuropathy, and you really just need to look for it. We classify basically the progression of FAP in terms of what type of assistive devices people need. So if the patient can walk without assistance, they are in the early stage. If they need 1 cane or 2 canes or crutches, they are in the second stage. And once they become basically wheelchair bound. They are in the third stage. And the median survival, once you make the diagnosis of amyloid neuropathy, familial amyloid neuropathy, is 4.7 years. So it really is important to make the diagnosis fairly early. The neuropathy is length dependent, as I mentioned. It's sensory motor, and there is a higher prevalence of bilateral carpal tunnel syndrome, often out of proportion to the patient's manual activities. We mentioned the orthostatic hypotension. The GI manifestations are important. At least in a third of the patient, they will have an IBS-like pattern. They may have upper GI symptoms such as nausea, vomiting, and early satiety. And this combination with the early satiety leads to unintentional weight loss. And that's usually in the neurology clinic a red flag if there is a neuropathy that we may be dealing with amyloid. And I mentioned sweat abnormalities as well as sexual dysfunction. Carpal tunnel syndrome can precede other TTR FAP symptoms by 5 to 10 years. And it's often bilateral, so it's usually a red flag if somebody gives you this history. In series that looked at the diagnosis of FAP, there was a diagnostic delay exceeding 3 years in about 30% of the patients. And usually the red flags, as I mentioned, are if there is autonomic symptomatology and signs, if there is cardiac involvement or renal involvement, rapid progression also, as I showed you, it's usually in 3 to 4 years, it's relentless. But perhaps more importantly in my practice is if someone has been misdiagnosed and say treated with immune modulating or immune suppressive therapy, and the neuropathy continues to progress, that should be a red flag that you are dealing with FAP. Alternative diagnosis, there was a series by Cortese that looked and found that about 49% in their clinic were misdiagnosed, and about 60% of those were misdiagnosed as chronic inflammatory demyelinating polyneuropathy, which is an autoimmune disease that affects the myelin. And about 20% or so were diagnosed with lumbosacral radiculopathy, yet imaging did not show stenosis adequate to explain the problem. And there was, additional few diagnoses, as you see, for instance, vasculitis, AL amyloid. But by far, about 83% of the patients were either misdiagnosed as CIDP, which is a condition really that's responsive to treatment. So if you give patients immune modulating or immunosuppressive therapy, thinking it's CIDP and they do not respond, maybe, you are misdiagnosing these patients. When you look at the causes why misdiagnosis occurred, late onset patients tend to be usually an afterthought. So if you see somebody in their 60s with a neuropathy, you don't tend to think of amyloid right away. If the family history is negative, males for some reason seem to be missed more often. If the heart is not affected, and finally, if you biopsy a tissue, and like I showed, it's not always 100% positive. It comes back negative, the diagnosis can be missed. When we evaluate patients and we do the neurologic exam, we, particularly in amyloid, but also diabetes, we do the so-called neuropathy impairment score. And this is a scale that was developed at the Mayo Clinic to evaluate diabetic neuropathy initially, but because of the similarities with amyloid neuropathy, in view of sensory motor, autonomic, as well as carpal tunnel involvement, trials have basically used it to test medications. And the scale is basically looks at the weakness in 24 muscle groups, including cranial muscles, looks at the muscle stretch reflexes, and the sensation of the 4 modalities, light touch, vibration, joint position, and pinprick over the index finger and great toe. And 0 will be normal. It's a disability score, so 0 is normal. And then the scale goes up to 2 for sensation and reflexes if they are absent, and to 4 if there is complete paralysis. And this scale actually has proven to be very, very effective. But over time, to increase the sensitivity and perhaps specificity, they added 7 other parameters, and the scale became known as NIS plus 7. So what are the 7 parameters? Well, 5 of the 7 are nerve conduction studies, looking at 3 nerves in the lower limb, 1 sensory and 2 motor. And 2 out of 7 are basically detection of the vibrations threshold over the great toe. And then the heart response to deep breathing, which is a measure of autonomic, particularly parasympathetic function. And when they looked at this measure, actually, they found out in a trial looking at diflunisal treatment in patients with FAP, this measure was very good at detecting a significant difference between treated and placebo groups. at 1 and 2 years. And basically, as you see at 2 years, the scores increased by 26 points in the placebo group and only 9 points in the diflunisal group. The problem with this scale is, of course, it requires, experience testing. And also there is some overlap between, testing in the foot as well as weakness in the foot. So there might be some redundancy. But including both testings are very good. Another limitation in the scale is that patients who are totally numb over their toe versus people who are totally numb in their foot and leg will score the same on the sensory scale. So this can be potentially a problem. And then large fiber sensory function is emphasized because you only test the pinprick, while the other 3 sensory modalities are basically due to a large fiber impairment. And you only have the heart rate to deep breathing, so you're missing many of the other autonomic indices. And as you see, there is a progression of how this evolved. And this has been used also, the scale, not only diflunisal, but also used in disease silencing therapy. And it matches very nicely both with the FAP neuropathy stages, as well as a linear progression as the patient's peripheral neuropathy disability score progresses. So it's very, very good with the patient's symptoms as a functional scale. It was used also as a primary endpoint in both disease silencing therapy. And both disease silencing therapy, as you know, are quite effective in reducing the levels of TTR. But patients who were treated with disease silencing therapy, when you look at their NIS +7 progression, you basically cut it by more than 2-fold. You reduce their disability by half over 1.5 to 2 years. So this is incredibly useful. So I like to finish by my 2 take-home points. First is the best way really to diagnose amyloidosis is to consider it. And if you don't think of it, you can be pretty late and patients will progress. And when it comes to treatment, earlier is better. And with this, I want to thank you for your attention, and I turn the microphone over to Dr. Alexander.
Great. Thank you, Dr. Jarady, for a terrific overview on ATTR neuropathy. And I'd like to remind the audience, if you have any questions, please put them in the chat, and we'll get to them in the Q&A section. So now I'm going to jump into a talk looking at hATTR cardiomyopathy presentation and diagnosis. So with amyloid deposition in the heart, you get progressive thickening of the atria and ventricles, and this can manifest in a number of ways. Oftentimes in early ATTR cardiomyopathy, patients can have arrhythmias, particularly atrial fibrillation. And as the amyloid starts to progressively deposits in the heart and the ventricles, you get stiffening that leads to heart failure, particularly diastolic heart failure. And that presents with shortness of breath, volume retention, and an increasing need for diuretics. An important thing to note for ATTR cardiomyopathy is oftentimes patients are intolerant to beta blockers and ACE inhibitors, which are standard of care for many other types of heart failure. But in amyloid patients, it can lead to hypotension and low output heart failure. And I think that has a lot to do with the nature of the restrictive cardiomyopathy. I'd like to just point out and kind of reiterate some of the stuff that Dr. Jarady showed in terms of there can be a lot of extra cardiac signs of ATTR amyloidosis. You can get deposition of these amyloid species in tendons and ligaments, and that can manifest as bilateral carpal tunnel syndrome, ruptured bicep tendon tear, an example shown on the right with the Popeye sign, lumbar spinal stenosis. And the reason that it's important to look out for these types of potential early spots of ATTR amyloidosis is that these manifestations can often precede the diagnosis of cardiac amyloidosis by 5 to 7 years, so similar to what Dr. Jarady showed you for carpal tunnel syndrome. And so this can really, as we try to identify patients as early as possible, I think this is an important place to intervene before they have significant cardiac manifestations. How do we go about diagnosing ATTR cardiomyopathy? From a heart standpoint, it comes down to suspicion. So like Dr. Jarady said, having the early recognition is key. Some of the things that you might see on common cardiac testing, such as an electrocardiogram, would be signs of low voltage, such as shown here in the limb leads. You can get pseudo-infarct patterns, delayed R-wave progression in the precordial leads, and certainly any evidence of atrial and ventricular arrhythmias could be suggestive of an infiltrative cardiomyopathy, but are still relatively nonspecific signs. On echocardiogram, you can see evidence of hypertrophy in the ventricles, enlargement of the atria, as shown here. Occasionally, patients will have some degree of a pericardial effusion. On more advanced echocardiographic imaging, such as longitudinal strain, which looks at the contractility of different regions of the heart. In amyloidosis, the basal segments, so the closer to the valve, tend to be more impacted than the apex. And so what you can see is abnormal longitudinal strain in the bases with relative preservation of strain in the apex. And this apical sparing pattern is pretty unique to cardiac amyloidosis. Other conditions such as hypertensive cardiomyopathy or hypertrophic cardiomyopathy tend not to have this type of pattern. If we look at cardiac MRI, you can get a lot of the same morphologic information that you would from an echocardiogram. There's some more specific tissue characterization that you can get as well, with abnormal signs of scarring through the presence of late gadolinium enhancement. T1 mapping can also give you an understanding if there's other material inside the ventricle other than myocardium. So if you have an elevated extracellular volume, that's something that's typically not seen in other cardiomyopathies. And so that could lead you to suspect cardiac amyloidosis. So all these things I think should prompt further workup, but they're, I want to emphasize that they're not specific to ATTR cardiomyopathy. So these should prompt you to do definitive tests. And so the gold standard would be biopsy, which Dr. Jarrett has gone over for neuropathy. These are sections of myocardium, and similar to the nerve biopsies, you can see that there's a lot of this light pink material that's really encasing these cardiomyocytes, which are in pink, and that's what leads to the arrhythmias and diastolic dysfunction that we see in the disease. So this presence of amyloid can easily be detected with Congo red staining and other histologic stainings, and then the confirmation of the subtype can be done by immunohistochemistry or mass spectrometry of amyloid fibrils cut from these slides. So endomyocardial biopsies certainly are invasive, and we want to pursue those when we have appropriate suspicion, but we've been fortunate in the last few years to have a non-invasive alternative for diagnosing this disease, and that's bone scintigraphy imaging. The most commonly used tracer in this country is technetium pyrophosphate. It's avid for ATTR amyloid fibrils, and post-injection of this tracer, if you were to perform imaging, you would see uptake in the myocardium as shown this representative image on the left here, and that would be diagnostic of cardiac amyloidosis. And other forms of cardiac amyloidosis, such as light chain amyloidosis, tend not to have the same uptake of technetium pyrophosphate. So in large studies done at centers that with expertise in this, they found that the sensitivity is around 99% with a specificity around 86. The reason the specificity was a little bit lower is that occasionally patients with light chain amyloidosis or AL amyloidosis can have a positive pyrophosphate scan. That's about 1 in 5. So in order to rule out this possibility, we recommend, and this is in society guidelines now, is to order serum-free light chains and serum and urine electrophoresis with immunofixation. This will evaluate for the presence of a monoclonal immunoglobulin. And if you rule it out with these tests, then that effectively rules out light chain amyloidosis or makes it extremely unlikely. And so you can be reassured when you get a positive pyrophosphate scan that is due to ATTR amyloidosis. So a hematologic evaluation to exclude a monoclonal gammopathy should always be done prior to ordering this test. And if you confirm the diagnosis with the pyrophosphate scan, then you avoid the need to do a heart biopsy. So there's been increasing interest in developing screening algorithms or identifying populations of patients to perform this testing in. And these are some guidance or recommendations from a number of amyloidosis experts that was published a little over a year ago. And they suggest that if you have someone with heart failure or red flag symptoms, and those would be things like the carpal tunnel syndrome, bicep tendon tear, et cetera, or abnormal strain on echo, characteristic MRI findings, and you have someone with increased wall thickness. If it's a male over the age of 65 or female over the age of 70, then it'd be reasonable to screen someone like that for ATTR cardiac amyloidosis. And you would do a hematologic evaluation first, and if that's negative, you can proceed to do a pyrophosphate scan, and a positive study would confirm the diagnosis. If there is a presence of a monoclonal gammopathy, then you would need to do a biopsy to confirm this disease. So why do we care about diagnosing this, and why do we need to diagnose this early? Well, we have treatments now. Dr. Jarrett showed you that there's a couple of transthyretin silencing agents that work by reducing TTR expression, and those have been studied in neuropathy populations. There's been a drug called tafamidis that's been studied in a cardiomyopathy cohort, and tafamidis is a stabilizing protein, or stabilizer, which means it binds to the TTR tetramer and stabilizes it, thereby reducing the amount that dissociates into monomers and subsequently reducing the amount of transthyretin that forms new amyloid. So this was studied in patients with either wild type or hereditary ATTR cardiomyopathy, and they had New York Heart Association class 1 to 3 heart failure. And what this study found was that at 30 months, patients who received tafamidis had statistically significant reduction in mortality and cardiovascular hospitalizations compared to the placebo group. And you can see that the curves start to separate as early as 18 months. It's important to highlight in this study that in the subgroup analysis, when patients were stratified into earlier stage heart failure, so New York Heart Association class 1 or 2 versus those that are class 3, the class 3 patients had less of a benefit from tafamidis, which likely reflects that in patients that have significant amyloid, the effect of tafamidis is attenuated. And that, I think, goes along with the mechanism of action, knowing that this drug stabilizes transthyretin and reduces new amyloid from forming, but probably does a lot less for removing amyloid that's already deposited in tissues. Hence, really finding patients when they have little or no cardiac amyloid deposition is really the time to intervene and start treatment. It's encouraging that we have a number of other novel therapies that are being studied in clinical trial, including several phase 3 studies looking at stabilizers and silencing therapies in this cardiac amyloid population. There's some earlier phase studies looking at monoclonal antibodies to help bind to existing amyloid fibers and remove them, and that could potentially be a complementary therapy to some of these stabilizers and silencers that really work on preventing new amyloid from forming. So in summary, I'd like to say that cardiac amyloidosis, ATTR cardiac amyloidosis, is an underdiagnosed cause of heart failure, particularly among African Americans. We're fortunate that effective therapies have emerged, but the early diagnosis is key for having an impact on this disease and the best outcomes. Keep an eye out for extracardiac manifestations of this disease, because those oftentimes are the earliest clue that someone is starting to deposit amyloid. And bone scintigraphy imaging can be a non-invasive alternative to diagnose ATTR cardiomyopathy, but it's absolutely imperative that you rule out a monoclonal gammopathy, because the last thing you would want is to have a positive pyrophosphate scan and treat someone as ATTR when they in fact have AL or light chain amyloidosis, which is a completely different disease that has an untreated median survival of 6 months. And so that error in diagnosis could have life-threatening consequences. So I'd like to thank you for your attention. And once again, any questions about my talk, Dr. Jarrett's, please put them in the chat. And at this point, I'd like to introduce our next speaker, Dr. Narissa Haynes, who's a cardiologist at the University of Pennsylvania. She's going to talk to us about health disparities among African Americans, challenges and solutions. And I think her perspective will be really helpful for taking observations from other cardiovascular diseases and how we might implement those to help with our how we manage this disease, ATTR, among African Americans. Dr. Haynes.
Okay, great. Thank you, Kevin, so much for the introduction. So I will be discussing 2 cardiomyopathies with significant ethnic disparities regards to prevalence as well as severe disease severity. So I'd first like to start with peripartum cardiomyopathy. So peripartum cardiomyopathy is a diagnosis of exclusion. It is defined as an idiopathic cardiomyopathy characterized by left ventricular systolic dysfunction that occurs towards the end of pregnancy or in the months following pregnancy or in the postpartum period. Diagnostic criteria performed usually with echocardiography with an EF or an ejection fraction less than 45%. The incidence of peripartum cardiomyopathy varies significantly based on geography, with some of the lowest incidence rates in Japan, as you can see here, with an incidence of 1 in every 20,000 live births, compared to much higher incidence rates in Haiti at 1 in every 300 live births, in Nigeria at 1 in every 100 live births. There are also tremendous and glaring racial disparities when it comes to peripartum cardiomyopathy. Studies have shown that peripartum cardiomyopathy disproportionately affects women of African ancestry. In America, for example, over 40% of peripartum cardiomyopathy cases occur in African Americans. And based on state-level data, the rates of peripartum cardiomyopathy can range from 3 to 16 times more likely in African American women when compared to white women. Additionally, African American women tend to be diagnosed with peripartum cardiomyopathy at younger ages, and they tend to present later in the postpartum cardiomyopathy period. Additionally, when African Americans are diagnosed with peripartum cardiomyopathy, they often present with lower ejection fractions, with ejection fractions less than 30%. They're more likely to present with this low ejection fraction. As mentioned, one of the main risk factors for peripartum cardiomyopathy is African ancestry. However, preeclampsia is another major risk factor, as well as pre-existing hypertension, multi-gestational pregnancies, and older maternal age. Another tricky thing about peripartum cardiomyopathy is that the symptoms tend to overlap significantly with pregnancy, such as lower extremity edema or swelling and shortness of breath. In terms of the pathophysiology of peripartum cardiomyopathy, the etiology is not fully understood. What does appear clear is that the etiology is most likely multifactorial. There are a number of suggested mechanisms that include nutritional deficiencies and viral myocarditis. What seems most likely, however, is this two-hit hypothesis, which you can see here. So the first hit is most likely a genetic predisposition. The second hit is defined by an antivascular environment in the peripartum period. In regard to genetic predisposition, a study published in the New England Journal of Medicine in 2016 found that among a cohort of women with peripartum cardiomyopathy, 15% had truncating genetic mutations. Most of these mutations were identified in the titin gene. Additionally, a higher prevalence of titin gene truncations were identified in women of African descent. In regard to the vascular and hormonal component, mice models suggest that peripartum cardiomyopathy may be in large part a vascular disease mediated by the hormonal environment of pregnancy. To provide a little bit more detail, prolactin, which is secreted in pregnancy to promote lactation, under oxidative stress may be cleaved to create a toxic prolactin fragment, which you can see here. And this prolactin fragment can cause myocardial injury as well as apoptosis. Additionally, VEGF may be inhibited in late gestation due to increased levels of soluble FMS like tyrosine kinase 1, known as SFLT1, which you see here, which inhibits VEGF. So the hypothesis is that with a genetic predisposition, elevated SFLT1 levels, and cleavage of prolactin due to oxidative stress, this may predispose some women to developing peripartum cardiomyopathy. So how do we manage and diagnose peripartum cardiomyopathy? So in regards to management, these patients should be put on a heart failure regimen. For women who are diagnosed during their last trimester of pregnancy, this would include beta blockers and nitrates. ACE and ARBs, as well as aldosterone inhibitors, are contraindicated during pregnancy. After pregnancy, though, beta blockers, enalapril, and spironolactone can be started and are compatible with breastfeeding. When it comes to anticoagulation, that should be started in women who have evidence of a thrombus, a left ventricular thrombus, and should also be considered in those with a reduced ejection fraction of below 35%. There are a few experimental treatments as well, such as bromocriptine, which is a dopamine agonist, which inhibits the release of prolactin. Family planning is also extremely important and encouraged, since repeat pregnancy with a reduced ejection fraction is associated with elevated morbidity and mortality. When it comes to prognosis, out of all the cardiomyopathies, rates of recovery for peripartum cardiomyopathy are pretty good. Frequently, women recover their ejection fraction within 3 to 6 months or up to 2 years. However, a lower ejection fraction, African ancestry, and delayed diagnosis are associated with worse outcomes. I would next like to talk about hypertensive cardiomyopathy, which is defined as the presence of left ventricular hypertrophy or left ventricular systolic or diastolic dysfunction and clinical manifestations of heart failure in those who have hypertension. In regards to prevalence, non-Hispanic Blacks have the highest prevalence of hypertension. So as you can see here, for adults aged 20 years or older, the prevalence of hypertension is 42% among Black Americans. This highlights also the importance of detecting hypertension as soon as possible, because there is also evidence that African Americans develop high blood pressure at younger ages. Hypertension is another major cause of adverse cardiovascular outcomes and cardiovascular mortality. And as you can see here, although mortality for heart disease has decreased for all Americans, disparities remain, and Black Americans are more likely to die of cardiovascular disease than any other group. And here, I would really like to drive home the point that hypertension is rightfully known as the silent killer. Hypertension can negatively impact almost every organ system, as you can see here, including the heart. So I'd like to just touch on the pathophysiology of hypertensive cardiomyopathy very briefly. Traditionally, hypertensive cardiomyopathy was thought to be purely compensatory, a compensatory response characterized by hypertrophy or thickening to decrease wall stress and maintain cardiac output in the setting of high afterload. However, there are many individuals who have hypertension who do not go on to develop hypertensive cardiomyopathy. Therefore, a more likely explanation is that there is also a genetic predisposition for hypertensive cardiomyopathy, as well as a constellation of contributing factors such as diabetes, chronic kidney disease, age, and gender. This slide shows the different cardiac profiles that can occur in response to hypertension. The first two profiles that you can see here show concentric hypertrophy or thickening of the myocardial walls. The third profile, which you see here, is eccentric hypertrophy, which is defined as an increase in LV mass while maintaining wall thickness, so that you don't have thickening in eccentric hypertrophy. All three of these profiles can be seen in response to hypertension. It is also possible for some patients or some individuals with hypertension to move from concentric hypertrophy to eccentric hypertrophy, either in the presence of ischemia, myocardial infarction, or without ischemia. Studies have shown, however, that most of the time, when individuals go from having concentric hypertrophy to eccentric hypertrophy, there is also ischemia or evidence of ischemia. So when it comes to hypertensive cardiomyopathy, again, there are glaring disparities when it comes to race. there is a much higher prevalence of hypertension and hypertensive-related heart disease in African Americans. Also, the prevalence of malignant hypertrophy, which is defined based on EKG criteria and positive troponin, is extremely high, threefold higher in Black men and women compared to white men and women. Additionally, those with severe hypertrophy are more likely to develop heart failure symptoms. I would like to close with a case. So this is a patient that I saw in clinic. She's a 65-year-old African-American woman with severe hypertension, with systolic blood pressures commonly in the 190s to low 200s. And what I would like for you to see here is how hypertrophied her walls are in this parasternal long axis view. We can see the severity of her hypertrophy also in this short axis view as well. She did go on to have a cardiac MRI, and the reason for that was on her echo, as you can see here on the right, her wall thickness was extremely high, 1.4 centimeters for her septum and 1.43 for her posterior wall. That prompted further investigation, and she went on to have a cardiac MRI, which showed severe hypertrophy. The measurements of her wall thickness on the cardiac MRI were as high as 2.2 centimeters. And I point this out because with such severe hypertrophy, we start to think of other conditions such as amyloid, as well as hypertrophic cardiomyopathy. Given this concern, she was sent to hypertrophic cardiomyopathy specialists who did genetic testing, and she was also ruled out for amyloid. So I think it's important as physicians for us to do our due diligence when we have hypertensive patients, especially those who are African American, to make sure we rule out other conditions such as amyloid or hypertrophic cardiomyopathy before we attribute their hypertrophy to hypertension alone. So how do we overcome some of the disparities that I just outlined, specifically when it comes to hypertensive cardiomyopathy and peripartum cardiomyopathy? So first, looking at hypertensive cardiomyopathy, improving healthcare access is key. Having access to primary care physicians who are able to do early detection and early screening for hypertension is absolutely critical, especially since we know that African Americans often develop hypertension at younger ages. Along those lines, many studies have shown that community-led hypertension programs are very effective, and they're very effective at catching young African Americans who may start to develop hypertension. It's also very important to educate our patients and to teach them about healthy lifestyle modification, and to make sure that we treat our patients aggressively, meaning that we really get their blood pressure to target. And lastly, for hypertensive cardiomyopathy, it's important to keep in mind how social determinants of health may be impacting our patients. For example, we know that poverty, education, and neighborhood quality directly impact cardiovascular health. And so for that reason, social policy is also health policy. So it's important to keep that in mind. For peripartum cardiomyopathy, a lot of the same things are true. Improving access is key. There are many women who do not have access to prenatal care, and there are disparities between African American women and white women in terms of access to prenatal and postpartum care. When a woman is identified as being high risk, it's important to implement a multidisciplinary approach to her care, and that those women should have early referrals to cardiologists as well. There should be a low threshold to perform a transthoracic echo for women who have risk factors and who are complaining of symptoms. So again, not to just attribute any edema or shortness of breath to pregnancy, especially if they have risk factors for peripartum cardiomyopathy. And lastly, for both hypertensive cardiomyopathy and peripartum cardiomyopathy, more research is needed. However, this research needs to be done in a culturally respectful way with a diverse cohort of investigators so that we can move the field forward and address these disparities. Thank you.
Sorry. Yeah, so thank you, Dr. Haynes, for a terrific talk. And now we're going to move for the next 10 minutes or so into a panel discussion to invite people in the audience to submit their questions. And we already have a few here, so I'm just going to get started. So the first one, I'm going to distill it down a little bit, but I'd like Dr. Jarity to comment on this first. So someone has a 35-year-old African-American female patient who's had suspected peripartum cardiomyopathy. They did genetic testing and found that she has the V122i variant. They did a pyrophosphate scan that was negative, and EMG was negative as well. And so now the question is, she's gene positive, but her imaging thus far from a cardiac and nerve standpoint are negative. How would you proceed with monitoring? And I think this kind of comes to a bigger question. I'm sure Dr. Jerry, like you, like myself, get a lot of patients now where they undergo genetic testing for one reason or the other, are positive for one of these variants, but are fairly clinically asymptomatic. What's your approach to following these young patients with TTR mutations?
Yes, thank you. Actually, that is an excellent question and is becoming increasingly relevant and important. So I will perform a neurologic exam on these patients, and if the nerve conduction testing is intact, I would ask about the autonomic symptoms as well and look to see if carpal tunnel testing was evaluated. If there are autonomic manifestations, perhaps I would obtain at least some objective measure of autonomic function testing, because that probably will lower my threshold to treat them. All in all, though, if really the nerve conduction testing is fine, and if the neuropathy score is very, very minimal, let's say less than 5 points, my approach will be to treat those patients with disease stabilizing therapy. And then, of course, focus mostly on the cardiac situation, but I would follow them periodically and fairly closely, because like I showed in the slides, once the peripheral nerve becomes affected, basically there is no point of reversal. The neuropathy will be relentlessly progressive, and sooner or later it will manifest itself. And and when you start seeing abnormalities in their NIS, neuropathy score, when they see abnormalities in the nerve conduction, with or without autonomic testing, they become candidate for more aggressive, disease silencing therapy. That's how I approach these patients.
Thanks, Dr. Jarity. Yeah, I have a similar approach from a cardiac standpoint. I think the person that submitted the question, we've done the same things with an echo and pyrophosphate scan. And if those are negative, I would just follow those patients closely, longitudinally. 35 years of age, it's on the younger side for developing amyloidosis for V122i. And so, I'd be comfortable kind of following that person longitudinally for any early signs, like you said in the question, because you really want to start treatment as early as possible if there's evidence. It's important to highlight that the penetrance for these variants is not 100%. So just because you have a variant doesn't necessarily mean you'll go on to develop amyloid. That's a large reason why we don't just put everyone on treatment. Something to consider that I've considered in my practice is in cases where they're relatively asymptomatic, is to consider something like diflunisal, which is a non-steroidal anti-inflammatory drug that has TTR stabilizing properties. Now, of course, this is an off-label use for that drug, but it's something that for some people that are kind of in that preclinical stage to consider. And so that's what I'd say about that. So the next question I want to ask for Dr. Haynes. So, in your last summary slide, you talked about some of the things for hypertensive cardiomyopathy and peripartum cardiomyopathy for reducing disparities. What parallels do you see for cardiac amyloidosis, for what you can take from what we've learned from those diseases to try to apply to improving outcomes in ATTR amyloidosis?
Yeah, I think that education is very important, and having a low threshold to test for amyloid. I think just like my case, what happens a lot of times is that patients who have hypertension and who have very thick hearts, it just gets attributed to hypertension alone and no further investigation is ever done. So I think especially in African American patients, even if they have hypertension, if they have extremely thick hearts and the rest of the clinical presentation fits, they should be tested for amyloid. So I think that's important as well, early detection and early screening, and for providers, even providers who are not cardiologists, to have amyloid on their differential so that they're able to refer patients quickly so that they could be treated.
Great. Thanks. And so, yeah, you're popular. So there's another question for you. So with hypertension being so prevalent in the Black community, there's a general public perception that this is because it's so common and it may not be a significant issue. Can you elaborate on the methods to educate patients on the seriousness of hypertension, which could lead to more severe pathology such as hypertensive cardiomyopathy?
Yes. So I think part of the problem with hypertension is that, people can walk around with very elevated blood pressures for a long time and feel okay. And one way in which to spread the word, I think, is meeting people where they are. So, in my slide, I mentioned community-led initiatives. There have been a number of studies. There was actually a barbershop trial that was published in the New England Journal of Medicine a few years back that utilized health promotion and education by barbers and barbershops. And that was tremendously effective. Where men would go in to get their hair cut, the barbers were educated on hypertension and hypertension screening, and they would have conversations with their clients who would then get screened in the barber shop for high blood pressure. And they were able to identify many men and some young men who already developed hypertension and were then plugged into care. So again, I think it's just meeting people where they are and trying to make the message understandable and relevant to that population.
Great, thanks. So I'll take this question. The question is, what is the prevalence of amyloidosis in the general population, and what's the prevalence for the familial version? So the short answer is there's not great observational data for the true prevalence of this disease, of ATTR amyloidosis. What we can infer from a number of observational studies that is quite a bit more common than I think a lot of people would perceive. There's been a number of studies looking at heart failure with preserved ejection fraction populations, people of the age of 50 with really minimal wall thickness, so 12 millimeter wall thickness. And screening in those populations, the prevalence of TTR amyloidosis is about 15%. So, I think any general internist or cardiologist who's on the wards and takes care of 6 HFpEF patients over the age of 50, one of them could have ATTR amyloidosis. I think in many busy practices, you're talking about multiple cases on service in a month. People have looked at other populations such as hypertrophic cardiomyopathy and doing amyloid screening, and 1% to 2% of those patients have underlying ATTR when they've been previously labeled as hypertrophic cardiomyopathy. So those are some of the data that we have to kind of get at that this is probably a bigger proportion of heart failure patients than was previously thought. And then I think with the familial form, certainly with V122i being carried by over 1 million African Americans in this country, even with the incomplete penetrance, that's still going to lead to thousands of patients going on to develop cardiac amyloid. So we definitely need the studies to better characterize that, but these data start to pick at this being more common than we thought. So let's see, maybe time for one more quick question. So the question is how is Antiprobinp and BNP used in evaluation of cardiac status in these patients? It has been used in severity scores, such as the Mayo Clinic, for looking at earlier and later stage disease patients. As you know, BNP is somewhat nonspecific, so it usually will be elevated in people that have a significant degree of cardiac amyloidosis. How to use this biomarker longitudinally is still has been worked out well, but I would say people with advanced amyloid disease will tend to have higher NT-proBNP than those that have, say, preclinical cardiac amyloid. So I think we're at the top of the hour. So with that, I'd like to thank Dr. Jaraday, Dr. Haynes for terrific talks today, and really, I think did a lot to raise awareness around ATTR amyloidosis, as well as the disparities that exist in minority populations. I think that this is one of a number of things that educational series we have at the ABC, and we encourage you to avail yourself of some of these seminars in the future. And with that, for anyone that's interested, I'd encourage you to apply for membership. Here's the website information for the ABC organization on this slide. And with that, I'd like to thank everyone for their attention and hope you enjoy the rest of the weekend.